नमस्ते बिटिया, हमेशा खुश रहो बिटिया। Myself, JB and Dr. Ravi Jain, Associate Professor, Department of Practice of Medicine and Faculty of Homeopathic Science at JYOTI VIDYAPEETH Women's University, Jaipur. On 24th May 2024, we are going to discuss about various disorders related to the old age. In the last lecture, we have discussed about the various changes of aging. Right? We have discussed what is aging and what are the various factors that leads to the development of aging, and various theories we have discussed, and we have also discussed about the various changes of aging. Today we are going to discuss in various disease condition related to aging. So let us start with the aging process and various disorders related to aging. So now let us start with the first disorder of aging, that is frailty. What is frailty? Frailty is defined as the loss of an individual ability to withstand minor stresses. So what is frailty? Frailty is the loss of individual's ability to withstand minor stresses because the reserves in the function of several organ systems are so severely reduced that even a trivial illness or adverse drug reaction may result in the organ failure and death. So what is frailty? Frailty is the individual's ability, loss of an individual's ability to withstand minor stresses. The person with the aging is not able to withstand minor stresses because the reserve in the function of several organ systems are so severely reduced that even a trivial illness, even a small illness or adverse drug reaction may result in organ failure and death. The other condition is disability. What is disability? Disability indicates the established loss of function. In disability, there is established loss of function, example, mobility, while frailty indicates the increased vulnerability to loss of function. So what is the difference between disability and frailty? In disability, there is established loss of function, whereas in frailty, this is indicating increased vulnerability to the loss of function. Now, what are the presenting problem of geriatric medicine? Whenever a person of the old age is coming to us, what are the presenting problems with he or she can come to us? The presenting problems in geriatric medicine includes most problems are multifactorial. These problems are multifactorial, and there is a relatively uniform diagnosis. Two patients who share the same presenting problem may have a completely separate diagnosis. We have late presentations, we have atypical presentations. In the late presentation, many people may tolerate symptoms for lengthy periods before seeking a medical advice. Angina may only present when the coronary artery disease is advanced. So late presentation, which are coming after a very long period of time, when a person is suffering from a disease condition for a very long duration, and then the presentation that is occurring is known as late presentation. Atypical presentation is the infection that may present with acute confusion and without clinical pointers to the organ system affected. Myocardial infarction may present as weakness and fatigue without any classical symptom of chest pain or dyspnea. So what is atypical presentation? An atypical presentation, atypical means not the typical features. Some features, some sign and symptoms are present which are not the typical features of the disease, but are present with the disease condition. Like the infection may be present with acute confusion and without clinical pointers to organ system affected. And the second example is MI, myocardial infarction may present as weakness and fatigue without the classical symptoms of chest pain and dyspnea. Acute illness and changes in the functions. To establish the patient's current status, the change from the usual level of functions. There can be multiple pathology involved, like a number of causes for any single problem, and adverse effects from medication often contributes. Now, approach to presenting problems. How can we approach towards the presenting problems of an individual? Number one, obtain a collateral history. We have to obtain a collateral history from the patient. and then check for all the medications. All the medications have to be checked for. Search for and treat any acute illness. And fourth is identify and reverse the predisposing risk factors. So how can we approach to the presenting problems of an individual? Number one, obtain a collateral history. A collateral history has to be obtained from check all the medication. We have to check all the medication a person is taking for the disease condition and search for and treat for any acute illness. Identify and reverse the predisposing risk factors. Next is screening investigation for acute illness. Whenever a person is coming for acute illness, how can we screen for the acute illness in old age person? Various tests can be performed, which includes full blood count, urea and electrolytes, liver function test, calcium gluconate. We can go for chest X-ray, electrocardiogram, urine analysis for leukocytes and nitrates, if positive, urine culture. C-reactive proteins, useful markers for occult infection, and blood cultures if pyrexia is present. Now, screening investigation for various types of acute illness includes the full blood count, urea and electrolytes, liver function test, calcium and glucose, chest X-ray, electrocardiogram, urine analysis for leukocytes and nitrates, if positive, urine culture. C-reactive proteins, useful marker for occult infection, and blood cultures if pyrexia is present. Now, what are the common problems under consideration? The common problems under consideration in case of old age includes falls. Fall means tendency to fall easily. Delirium, urinary incontinence, adverse drug reaction, dizziness, and other problems of the old age. So what are the common problems under consideration of old age? It includes falls, delirium, urinary incontinences, adverse drug reaction, dizziness, and other problems of the old age. Number one, fall. Around 30% of those aged over 65 years fall each year. Fall also leads to serious injuries like hip fracture, loss of confidence, and fear. Due to acute illness, common infection, stroke, and metabolic disturbances, the heart failure, or any such drug which precipitate falls. There can be blackouts which can introduce syncopal episode, risk factors which includes muscle weakness, history of falls, gait or balance abnormality. Now, what are falls? Falls around 30% of those above 65 years of age fall every year. This leads to various serious injuries like hip fracture, loss of confidence, and fear. Due to acute illness, common infections, stroke, metabolic disturbance, and heart failure can occur. Blackout can also there, that is caused by syncopal episode. The risk factors of falls includes muscle weakness, history of falls, gait or balance abnormality. Using a walking aid, visual impairment, arthritis, impaired activities of daily living, depression, cognitive impairment, age over 80 years of age, and psychotropic medications. Now, what are the intervention? What are the things that could be done in case of falls? Individualized or group exercise training can be advised. Rationalization of the medicine. Only essential medicines are required. Correction of visual impairment. Home environment, hazard assessment, and safety education to be given, and treatment of the cardiovascular disorders. So what is the intervention in case of falls? The intervention includes individualized or group exercise training, rationalization of the medicines, correction of visual impairment, home environment, hazard assessment, and safety education, and treatment of the cardiovascular diseases. So this was all about falls. Next, we come to delirium. What is delirium? Delirium is an abrupt change in the brain that causes mental confusion and emotional disruptions. So, delirium is an abrupt change in the brain that causes mental confusion and emotional disruption that makes it difficult to think, remember, sleep, and pay attention. Delirium may be the first presentation of underlying dementia. This is very common. Delirium is very common, that is affecting around 30% of the individuals. Now, the diagnostic criteria of delirium. Number one, disturbed consciousness with reduced ability to focus. Number two, a change in the cognition, example, memory, language, and orientation, or development of perpetual disturbance that includes hallucinations that is not accounted for by a pre-existing developed dementia. So diagnostic criteria includes disturbed consciousness with reduced ability to focus, Number 2, a change in the cognition, example, memory, language, orientation, or development of a perpetual disturbance like hallucination that is not accounted for by a pre-existing developing dementia. Number 3, development of the disturbance over a period of hours and a tendency to fluctuate over the course of day. Number 4, evidence from the history, physical examination, or lab finding that the disturbance is caused by the direct physiological consequence of a general medical condition or by substance intoxication or withdrawal. So, development of disturbance over a short period of time, hours or days, and a tendency to fluctuate over the course of day. Evidence from history, physical examination, lab findings that the disturbance is caused by the direct physiological consequence of a general medical condition or by substance intoxication and withdrawal. Now, what are the risk factors for delirium? The risk factors includes old age, dementia, admission with infection or dehydration, surgery for hip fracture repair, alcohol misuse, severe physical illness, frailty, visual impairment, polypharmacy, renal impairment. So what are the risk factors? The risk factors includes old age, dementia, admission with infection or dehydration, surgery like hip fracture, alcohol misuse, severe physical illness, frailty, visual impairment, polypharmacy, and renal impairment. Now, how to assess a case of delirium? The clinical assessment is done by the following things. We have to check for the conscious level, the pyrexia and any sign of infection in the chest, skin, urine, or abdomen. We have to check for the oxygen saturation level, the signs of alcohol withdrawal, such as tremors or sweating, and any neurological sign. So in the clinical assessment, we have to check for the consciousness level, pyrexia, or any sign of infection in the chest, skin, urine, or abdomen. We have to check for the oxygen saturation, the signs of alcohol withdrawal, such as tremors and sweating, any neurological sign. How to manage a case of delirium? Specific treatment of the underlying cause has to be given. Environment should be kept well lit and not unduly noisy. The patient's spectacles and hearing aid should be kept in place, and good nursing care is required. So the specific management of delirium includes specific treatment of the underlying cause. Environment should be kept well lit and not unduly noisy. Patient spectacles and hearing aid should be kept in place and good nursing care. Another important disease condition that is seen in old age is the urinary incontinence. The urinary incontinence means involuntary loss of urine. The following type of urinary incontinence is observed in old age. Urge incontinence, that is due to the detressor overactivity and results in urgency and frequency. Second is stress incontinence. This is exclusively seen in women due to the weakness of the pelvic floor muscles. This allows the leakage of the urine when the intra-abdominal pressure rises, example by coughing and sneezing. Third one is the overflow incontinence, that is most commonly seen in men with prostatic enlargement in the elderly. So, involuntary loss of urine, that is seen in case of urge incontinence, stress incontinence, and overflow incontinence. The assessment and management of the urinary incontinence in the old age. How to assess? So, address the contributory factors like UTI, urinary tract infection, severe constipations, drugs like diuretics, hyperglycemia, hypercalcemia, restricted mobility, and acute confusion. If the patient is still incontinent, then establish the pattern of urinary loss, maintain residual volume, and assess the vaginal prolapse and atropic vaginitis. Assess the prostate by rectal examination. Now, how to manage a case of urinary incontinence? For urge incontinence, the bladder-retaining antimuscarinic drugs like solifacin and toltedirone should be given. Stress incontinence, pelvic floor muscle training, that is known as Kegel exercise, should be done, and surgical intervention if unsuccessful. And overflow incontinence, surgical relief of the obstruction and prostatectomy should be done. So this was all for today. In the next lecture, we will be continuing with this disease condition like adverse drug reaction. So this was all for today. I hope you must have understood this session properly. In the next lecture, we are going to cover the remaining disorders of the old age. So this was all for today. Thank you very much. Have a good day.